Tonight, someone may sit up in bed, open their eyes, stand, and walk into another room. They may avoid a chair, open a door, speak a few words, or search for something that is not there. To anyone watching, they may appear awake, but they may not understand where they are. Their judgment may be deeply impaired, and by morning, they may remember nothing. This is not simply a dream controlling the body. Part of the brain has become active enough to move, while the systems responsible for awareness, reasoning, and memory remain asleep. So how can a sleeping brain navigate a real house? And what should you do if the person begins moving toward danger? Sleepwalking, also called somnambulism, belongs to a group known as disorders of arousal. These events usually emerge from deep, non-REM sleep. The brain begins to wake, but the awakening does not finish. The result is neither ordinary sleep nor ordinary wakefulness. It is a mixed state. The eyes may be open, the body can sit, stand, or move, but the person may stare through the room rather than truly inspect it. They may respond slowly, speak unclearly, or fail to recognize someone nearby. Their behavior can look purposeful, while awareness remains incomplete. And walking is only one possibility. Some episodes involve sitting up, mumbling, arranging objects, opening cupboards, or repeating a simple action. The body is active. The person is not fully present. To understand how that is possible, we must stop imagining the brain as one machine that is either completely on or completely off. During a normal awakening, many systems change state together. Awareness sharpens. Motor control returns. Memory begins recording. Judgment comes online. During sleepwalking, that coordination appears to break apart. Research suggests that some motor and emotional networks can show wake-like activity, while regions involved in higher reasoning, self-monitoring, and full environmental awareness remain sleep-like. This is called state dissociation. Different parts of the brain behave as though they belong to different states. Motor systems can release a familiar action. The eyes can remain open. Basic navigation may continue. But the brain may not construct the reflective awareness that normally supervises those actions. Imagine a building at night. The corridors and elevators switch on, but the control center remains dark. The sleepwalker is not pretending to be awake. They are moving through a real environment with a brain that has only partially returned. And sometimes, that partially awake brain can do far more than walk. Many episodes are simple. A child sits up. An adult walks toward a doorway. Someone mumbles, adjusts a blanket, or searches the room. But more complex behavior can occur. A person may dress, move objects, prepare food, use a bathroom, walk downstairs, or open an outside door. In rare cases, the behavior can become dangerous. It may look organized because familiar actions do not always require full reflective consciousness. Walking through a known hallway is different from solving an unfamiliar problem. Opening your own door is different from deciding whether leaving the house at night is safe. A sleepwalker may complete the familiar movement, without the judgment normally supervising it. Their eyes may be open, but visual awareness is not necessarily normal. They might avoid a large obstacle, yet miss a smaller danger. They may speak, but the words can be fragmented or disconnected from the real situation. The body can perform the habit. The conscious mind may never arrive to witness it. So what is guiding the behavior? Sleepwalking was once described as action without mental experience, a body moving through empty unconsciousness. The real picture appears more complicated. Some people report images, emotions, or fragments of thought after an episode. They may feel they were searching for someone, escaping something, or responding to a threat. But sleepwalking is not usually the same as acting out a vivid REM dream. That distinction matters. Sleepwalking generally emerges from deep, non-REM sleep. REM sleep behavior disorder is different. In that condition, normal REM muscle paralysis is reduced or absent, allowing dream-related movements to reach the body. Sleepwalking begins with an incomplete awakening from non-REM sleep. The body gains movement while awareness remains disorganized. The two conditions may look similar from across the room, but their timing, mechanisms, and clinical meaning differ. Nighttime seizures can also produce unusual movements, which is why dramatic, repetitive, injurious, or adult-onset episodes may need medical evaluation. Not every movement during sleep is sleepwalking, and not every sleepwalker is acting out a dream. So, why does the incomplete awakening happen? There is no single cause for every episode. Sleepwalking appears to involve vulnerability plus disruption. Some people have a stronger predisposition, and family history suggests genetics can contribute. Then something makes deep sleep less stable. Sleep deprivation can increase pressure for deeper sleep while making awakenings more irregular. Stress, fever, noise, touch, a full bladder, an unfamiliar environment, or another sleep disorder may trigger a partial arousal. Obstructive sleep apnea can repeatedly interrupt sleep and may contribute in vulnerable people. Certain medications and substances can also be associated with unusual sleep behavior. Think of several conditions meeting at once: a predisposition, deep sleep pressure, and a trigger that pushes part of the system toward wakefulness without bringing the rest along. Sleepwalking is more common in children and often becomes less frequent with age, but it can continue into adulthood. When complex episodes begin suddenly in an adult, especially with injury, violent movement, daytime sleepiness, or highly repetitive behavior, they deserve closer attention. Because the first goal is not to decode a hidden meaning, it is to make the night safe. You may have heard that waking a sleepwalker is dangerous. That is not quite true. Waking them does not automatically cause medical harm. But a sudden awakening can produce intense confusion, fear, or defensive behavior. They may not immediately understand who you are or why you are touching them. When there is no immediate danger, the calmer approach is often to guide them gently back toward bed. Speak quietly. Move slowly. Avoid grabbing, shouting, or arguing with the confused story they may be following. But safety comes first. If the person is approaching stairs, a balcony, a road, a window, fire, water, or a sharp object, intervention may be necessary. The environment should provide much of the protection. Clear pathways. Protect stairs and windows. Secure outside access while preserving emergency escape. Restrict access to dangerous tools. Consider door alarms when wandering creates risk. The goal is not to imprison the sleeper. It is to prevent an impaired brain from reaching danger before anyone notices. Many episodes are occasional and require nothing beyond reassurance and safety. Recurring sleepwalking may improve when the factors destabilizing deep sleep are addressed. Getting enough sleep matters. A regular schedule matters. Treating insomnia, sleep apnea, restless sleep, or another source of repeated arousal may reduce episodes. Alcohol and medications should be reviewed with a clinician when they appear connected to the behavior. For predictable childhood episodes, scheduled awakenings are sometimes used. The child is gently awakened shortly before the usual event, interrupting the pattern. Sleep hygiene, relaxation, and multi-component behavioral approaches have some supporting evidence. But research remains limited, and no single method works for everyone. Medication is not automatically the first answer. It may be considered in selected severe or dangerous cases under medical supervision. A sleep specialist may use history, home video, sleep testing, or other evaluation when the diagnosis is unclear. The aim is to distinguish sleepwalking from seizures, REM behavior disorder, medication effects, and breathing-related sleep disruption. Strange behavior during sleep does not mean nothing can be done.